Good afternoon and welcome to What's Up, Doc. My name is Tia Tiriak, and I am pleased to welcome you, both our in-person audience and those joining us virtually. What's Up, Doc is a monthly lecture program provided by the Concord Hospital Trust, and we're proud to share with you the very latest in healthcare information, treatment options, and providers available through the Concord Hospital Health System. We want to recognize and thank the Walker Lecture Series, who are right here in Concord, for their generous sponsorship of What's Up Doc. Today's What's Up Doc program continues our effort to highlight Concord Hospital's Cardiovascular Institute and its incredible team of specialists. Dr. Chodosh is our guest speaker today, and Dr. Chodosh is going to talk about leaving blood thinners behind. Dr. Chodosh joined the staff of Concord Hospital in 2010. He attended Albert Einstein College of Medicine in New York. He completed his residency at Fletcher Allen Healthcare in Vermont, and then completed a fellowship at Brown University in Rhode Island. Truly a New England person. Dr. Chodosh is board certified in cardiovascular disease and clinical cardiac electrophysiology. Please join me in welcoming Dr. Chodosh.
My parents would roll over and they heard you say that I was a true New Englander. Because I'm from New York, actually, as it turns out. Can you all hear me? Okay, well, thank you very much for having me. I think one of the privileges of doing this is allowing me to take inventory in terms of how far things have really come in my world doing electrophysiology. And like I've said before, some of the procedures that I'm going to be discussing, I didn't even dreamt of them when I started this, when we started hearing, to think about how far we've come just for the Watchman procedure that you'll learn about here at this institution is really remarkable, and it just it fills me with pride knowing that we have such a great team and that we've done this procedure and done it well and really helped a community. Because when my dad, he was a physician, when he told me that he was congratulating me, I got the job here, and he's like, your sense of duty is not just for your patients, but the population of patients that you're caring for. And I think in keeping with that, I think this procedure really fills me with pride when I think about the fact that we're really helping a population of people. And it's also my duty, I think, to have these talks. And I really enjoy them just to educate people. And I really hope people stop me at any point with questions. I've left time, hopefully at the end, for questions. If anybody has any questions throughout, please let me know. So I have no disclosures, just for the record. And how I thought we organized, or I organized this talk, was to give a little bit of background of left atrial appendage occlusion, the rationale. So this appendage occlusion is doctor speak for we're going to find something and we're going to plug it up and stop it. And there are different tools that allow us to do that, which is why we use the term left atrial appendage occlusion as opposed to just the Watchman. But I think this will be very apparent to y'all as we go through the procedure, or through the talk rather. I'm going to touch on some of the data from the clinical trials, and I don't want this to be too heavy as far as statistics, but I want you all to understand about really why we do what we do, and really the data that supports what we do. So I thought that was really important. Anatomical considerations for this chamber of the heart. Our experience here, I thought we have some examples of interesting cases that we've done here, and then, as I said, I've left time for questions. So, with that said, let's get into atrial fibrillation. So, atrial fibrillation is just what I tell my patients is that it's one of the best heart problems to have, mostly because it just represents a quality of life issue. It's not a rhythm that's going to kill you. And in fact, I have lots of patients who do everything they want with atrial fibrillation. marathons. I have patients who've been in atrial fibrillation for decades, and if they sit there in front of me and say, listen, I feel fine, I don't even know I'm in atrial fibrillation, I universally tell these patients to stay away from doctors like me. And go live your life, and your life will be full and happy. And really what atrial fibrillation is, so normally electricity travels through our heart, and it travels in a very uniform fashion. And I liken it to imagine yourself standing over a pond and throwing a pebble into the pond on a very regular basis. That's how electricity normally acts and behaves. And atrial fibrillation is like me walking up to your pond with a fistful of pebbles and continuously throwing my pebbles into your pond. You now have a very chaotic distribution of electricity as all these pebbles are hitting your pond. And like I said, it's a quality of life issue. There are some exceptions to that, and the big exception is the fact that if you are a patient with atrial fibrillation, you are at increased risk of stroke. One of the popular questions I get from patients is, why is there so much atrial fibrillation around now? And I think it's multifactorial. I think first and foremost, the awareness of atrial fibrillation is out there. When you turn the television on, you see the term atrial fibrillation. There are doctors like me now who treat atrial fibrillation, and 20, 30 years ago, there weren't doctors like me around. And so I think for that reason, I think there's just much more awareness of atrial fibrillation. I think very importantly, we know that the prevalence of atrial fibrillation increases as we age, and the American population overall is aging. As we age and live longer, we're going to see more atrial fibrillation. And I think most importantly, I think the diagnostic tools that allow us to make the diagnosis have come a long way. Our ability to monitor patients has really progressed. You know, back way when you go to your doctor and you say, well, I have palpitations every few weeks, the tools really weren't there to make an accurate diagnosis. If you weren't in atrial fibrillation at the time of the visit, you probably wouldn't have been diagnosed with atrial fibrillation in a timely manner. And now we have all kinds of tools and monitors to really help us make that timely diagnosis. Generally speaking, you are at a 5-time risk of stroke if you carry the diagnosis of atrial fibrillation. And I'll go into why that is. Strokes, by and large, in patients with atrial fibrillation are more significant, they're more severe, they're more debilitating, and more often more fatal than other types of strokes. So 90% of strokes in patients with atrial fibrillation come from this area within the heart called the appendage, and I liken it to an earlobe. This is an ultrasound view of what the appendage looks like, and really what happens is when you have atrial fibrillation, you have stasis of blood flow in this chamber of the heart, and when you have stasis, clots can form in this chamber, and this is in fact what a clot looks like in the chamber of a patient who had atrial fibrillation and a clot. And this is what we're trying to prevent. This is the nature of stroke in patients with atrial fibrillation. So it turns out, when I was in training, I guess a while ago now, we were always taught to avoid this chamber at all costs. And it's really been one of those nice things because through my experience doing this procedure, I've become a lot more comfortable with doing things within the appendage for other types of procedures like ablation. But as it turns out, it is an incredibly complex structure. And we break it into 3 different morphologies, into 3 different shapes. The windsock pattern, which is this big kind of, looks like a windsock. This is what it looks like on CT. It's a big open area. The old chicken wing, which is my favorite, has this chicken wing appearance. And then the broccoli type, which is the most complex type, which has lots of what we call trabeculation here. And as it turns out, the more we study these morphologies, the more we recognize that certain shapes predispose to clot more than others. For instance, the broccoli shape actually predisposes one to a much higher risk of clot formation than the windsock. So when you go to your doctor and you have atrial fibrillation, what they're trying to do now is try to figure out what your risk of having a stroke is. And I tell patients that this is fraught. These are models that are population-based, and it doesn't necessarily apply to the patient who's standing in front of me. I tell patients that I've had patients who have the lowest risk, statistical risk of having a stroke and have actually had big strokes. And more often than not, I have patients who have very high risk and don't have strokes. So this is very difficult to predict, but we have used this very well-validated scoring system to determine one's statistical risk of having a stroke. And it's really called the CHADS-VAST scoring system. It was updated a few years ago to include certain predictors of stroke. But essentially, if you had or carry the diagnosis of congestive heart failure, if you have hypertension, if you are older than 65 or older than 75, if you have diabetes, prior stroke, vascular disease, or if you're female, these are all points that we know increase your risk of stroke. Essentially, if you carry a CHADS-2-VASC score of 9, essentially if you had all of those risk factors, you have about a 15.2% risk of stroke annually. This is if you are not on Ultrasound. Versus if you have a CHADS-2-VASC score of 0, it's actually 0. And that patient that I alluded to had a CHADS-2-VASC score of 0, but he had a big stroke. So again, these are statistical models, and you kind of have to keep that in mind. But ultimately, this is how the doctor, when you're sitting in front of he or she, tries to come up with, all right, what is your risk of stroke? And conversely, what's your risk of bleeding? I'll go into this in a second. Generally speaking, the guidelines state that if you have a CHADS-2-VASC score of 1 if you're a man, or 2 if you're a woman, you can be started on a blood thinner, or you should at least have that discussion, at least in aspirin, but I will tell you that aspirin is really falling out of favor, and the data for aspirin and stroke prevention in this patient population is really falling out of favor, and it's based on older data, and this is currently being debunked, but it's still a part of the guidelines. If you have a CHADS-VASC score that's higher, grade 2 or grade 3, oral anticoagulants are recommended, and if you have a CHADS-2-VASC score of 0, no anticoagulation is recommended. And part of the reason why it's not recommended is that blood thinners carry with it inherent risk for bleeding, right? And doctors are really trying to also quantify that risk, which is very difficult, I think, more so than the risk of having a embolic stroke for a variety of reasons. But this is another well-validated statistical model called the Hasbro Score. Essentially, if you carry any of these diagnoses, hypertension, abnormal renal or liver function, prior stroke, bleeding, you have labile INR, and I'll go into that in a second. Elderly, greater than 65, drugs or alcohol, you have, you get 1 or 2 points. And then you can put that into another scoring system that I'll show you later. But essentially, if you have a Hasbro score that's 5 or greater, your 10-year risk is actually about 50% of having a bleed if you are on a blood thinner. So essentially, what we're trying to do is come up with risk benefits as far as stroke prevention or bleeding prevention. Personally, I find that stroke is one of the worst outcomes of medicine. I find myself leaning towards more aggressive anticoagulation than some other doctors, simply because I don't want my patients to have strokes. And personally, I'd rather have a bleed than a stroke, but it's all relative. Blood thinners are not ideal for everybody. And historically, we have used a blood thinner named warfarin or Coumadin. And it's been around for a very long time. It's been well studied. And the problem with warfarin is that you have to monitor the levels frequently in order to make sure that you're in this range, what we call therapeutic range. We don't want your blood to be too thin or too thick. And the problem really with warfarin is that it fluctuates frequently in a lot of patients, depending on your diet, other medications you take. And for that reason, we have to check levels relatively frequently, usually on average somewhere between 1 and 4 weeks. And for a lot of people, that's just a pain, and it leads to non-adherence. There have been really a remarkable trend towards these direct oral anticoagulants. You've probably seen them advertised. Eliquis, Pradaxa, Xarelto are the 3 that reason, there is more adherence to these agents. Guidelines, I'll go into this a little bit, really are moving towards these agents. So, like I said, the issue with Coumadin is that you have to remain in this range here, usually between 2 and 3. 44% of bleeding events occur in patients above the therapeutic range. So that's a major problem. Conversely, if you're below this range, 48% of thromboembolic events occur in patients who have levels below 2. So it's really, really important that we strive for that range. And the other issue is that when you look at all the clinical studies that compare Watchman and Coumadin or the newer agents, Coumadin or warfarin, the problem is that when patients are enrolled in studies, it really does not represent real-life issues. These patients are very closely followed, so a higher proportion of these patients in these studies are usually in the 2 to 3 range than what we find in real life. I alluded to the Hasbro Score, the bleeding score. So I said if you're about 5, you have an estimated 10-year risk of 61.5% risk of bleeding over 10 years. That is not insignificant. It compounds over time, as you can imagine. So all of these factors have to factor into what blood thinner you decide on, or even if you should be on a blood thinner. This is a busy slide, and I apologize for this, but I think it underscores some very important points. So this slide here really is looking at this registry of lots of patients who are followed with anticoagulation over time, and we're looking at the CHADS-2 vascular score on x-axis here. Remember, 9 being very high, 0 being very low, and then the portion of patients who are on an anticoagulant on the y-axis here. And what you see is that it peaks at about 50%. About 50% of patients who carry the diagnosis of atrial fibrillation are on anticoagulation. That's abysmal, actually, as it turns out. I think the real thing that this really underscores is the fact that the higher your score, it kind of peaks at 50 if your CHADS VAS score is 5. But if your CHADS VAS score, risk of stroke, gets higher, lesser proportion of these patients are actually on blood thinners, right? So why is that? Well, it's because these patients are older and sicker and have a higher risk of bleeding. But this really, I think, frames the issue that we're up against, and why ultimately I'm really pleased to offer people to watch. So DOACs is the term for the newer agents, direct oral anticoagulants. That's what that stands for. Compliance is much better with these agents, but still, about 50% of patients who were started on warfarin will stop it at year 2, and for the DOACs, the Eliquis, Daxon, Xarelto, about 30% of these patients will stop it at year 2 for a variety of reasons. Again, this kind of underscores the same thing, but I want to also show. So the red is Coumadin or warfarin. Green, blue, and purple are the newer agents, and you can see that there's a higher proportion of patients as we moved on from 2011 through 2014, and more so now, who are on these newer agents. Still, nearly 40% of patients who should be taking anticoagulants are not. One of the issues with the newer agents is that they're really one great reversal agents. That really made me nervous when prescribing this to patients because Coumadin and warfarin both have reversal agents that are readily reversible, or readily available rather. And that has changed, thankfully. There are reversal agents that are very expensive, but they are available. And this has been an important, I think, an important kind of strategy for us to say, all right, this is probably a statement bet for you. Then comes in. So, anatomic consideration. So, as I told you, I was always taught, stay away from the left atrial appendage. Just don't go near it. And the reason for that is because it is very, very thin structure. It's actually 1 to 2 millimeters. So, during anatomy class, you can actually shine a light right through it, and you can see it. So you can imagine where that would be a concern if you're instrumented in this area. And it certainly is. So, we we know that this is the area where clots form, and doctors over time have really tried to come up with different ways, different avenues to occlude it. And Watchman is one of them, but there are several others. And so the first one I wanted to mention was really a very elegant, in my opinion, very elegant strategy to occlude the appendage, and that was epicardial, where the doctor goes in from the outside and sutures the appendage itself, thereby blocking it off. And one of the reasons why, in theory, it made a lot of sense was that you don't have to have patients on blood thinners during the procedure or immediately after, which was unlike the Watchman procedure, where anticoagulation or blood thinners are recommended for at least a short period of time. And for that reason, it really made a lot of sense. Unfortunately, there were lots of issues with tearing of the appendage, and when the appendage tore, bad things would happen. There was a black box warning put on malaria procedure a couple of years ago, and it is not being done routinely. It is still kind of in research. I think they're trying to work on making it a safe procedure, but to my knowledge, it is not happening anywhere clinically for most patients. The other problem with the lariat was that this would often open up over time, and that also presented an issue. So the newest device on the market is called the Amplatzer, made by Abbott, and it kind of looks like a clamshell, and it's currently FDA released about a month or two ago, and we're exploring looking at it, but I still think Watchman is superior to this for most anatomical appendages. The other thing that surgeons have been doing over time is they've been actually ligating. So sometimes when they're doing bypass surgery, they'll sew up the appendage, or they'll actually amputate the appendage. We have recently moved into this type of procedure called the atrial clip. So the surgeons can actually clip the appendage visually if they're there for another reason. I won't go into this type of procedure, but we started doing this new ablation called the convergent procedure, where the surgeons ablate a lot of tissue on the outside in an effort to keep somebody out of atrial fibrillation who's been stuck in a clip for a long time. But coupled with that, they will routinely do the atrial clip. So there are centers that will actually just do this as a surgical procedure, as opposed to the endovascular or percutaneous procedure we're about to learn about. So those are the only alternatives that are currently available in the United States. But the Watchman is really a procedure that we've had great success with here. And I'll go into some of the details, but essentially it's a minimally invasive procedure. Believe it or not, our portion now takes about 30 minutes. It doesn't take very long. And essentially, we are placing this Watchman device in the appendage itself percutaneously. People stay one night in the hospital typically, but we are exploring with sending patients home now. It's safe, it's effective, and I'm going to go into some of the data behind it. So very well studied, and I'm not going to belabor this, but there are lots of prospective studies starting in 2002 up until recently that have looked at how effective, how safe it is, and when this was released, I believe in 2014 by the FDA, there was lots of skepticism in the electrophysiology community. There were lots of doctors who were saying this is not the right thing. And one of the things I love about the field, again, is that it's rapidly evolving. And I liken myself as judicious when it comes to newer technologies. But the reality is that when you're dealing with newer technologies, you don't always have, the ability to predict how things are going to really turn out over time. And I will tell you, I held my breath a little bit. I really thought about it and said, I do think it makes sense for a certain population that we're dealing with who really don't have other good alternatives. But luckily, in 2018, there was a meta-analysis, which is essentially doctor speak for doctors combining all kinds of clinical trials in an effort to bolster the numbers and get more of what we call power. And it really validated the fact that this procedure is the right procedure so we stop that and start Plavix and aspirin from day 45 to 6 months. And at 6 months, you can stop it and you go right to aspirin. And this was a problem because there are patients who I'd see who had major bleeds, and you are scared to start blood thinners. And I will tell you, there's been at least probably somewhere between 6 and 10 patients who we've implanted the device in who we've had to stop some combination of blood thinners or antiplatelets, sometimes as soon as within a week of doing the procedure. More importantly, there's now data from Europe that really says you can forego some of this stuff. And to me, that makes it a lot more comfortable knowing that I'm putting this device in somebody who might have a major bleeding problem in the short term after it's implanted. That was always, when I started, a major concern for me. But the longer I do this, the more experience we get, the more comfortable I am in the situation. So I alluded to this meta-analysis that was published in the Journal of American College of Cardiology in 2015. And it looked at a few of the very landmark trials for the Watchman, and it compared how those patients did to patients who never got the Watchman. And believe it or not, there was an all-cause mortality reduction by 27%. Now, those are relative terms, so that's 4.9% in the warfarin arm and 3.6% in the Watchman arm. But for us, those are humongous numbers, and that's a real big benefit. And this is largely driven by the fact that patients who got the Watchman didn't have major bleeding issues. They didn't die from major injuries, which is really, I think, the major benefit of placing the Watchman in somebody, because you reduce that risk of bleeding over time. And it's a difficult metric for us to pay attention to, because how do you actually, we put Watchman in over 200 patients in 2016. Well, a lot of them aren't coming into the ER, they're not having bleeds. How do you quantify that? It's really not terribly easy, but this meta-analysis made me feel so much better in reviewing. So, as I said, it resulted in 70% major bleeding reduction and all bleeding at the 6-month mark. And that's kind of what this shows, and this is again from the meta-analysis that was published in 2018. More importantly, was that there was always concern, and I alluded to the fact that 90% of strokes in patients with AFib come from that appendage area. Well, that means that 10% of strokes actually come from other areas, right? So the reality is that you wouldn't think that the Watchman is as effective, right, as a blood thinner for that very reason. And you also worry about strokes that might come from the surface of the Watchman device or what have you. And it turns out that the strokes that patients do have, right, after the Watchman is implanted are less disabling and more often not fatal by 55%. So that is really, again, I think the new saving is that less bleeding, and the strokes that patients have after the Watchman is put in are generally smaller, less disabling, and less fatal. So our experience here, we've been doing it since 2016. We've had 223 cases. We've had to bring a number of patients in, and sometimes we look at what we see, and we actually don't implant the device for one reason or another. So we've actually brought a lot more patients in 2023. These are patients who left our lab with the Watchman device. We have an exceedingly low complication rate, and I'll explain to you why that is. In part, most patients have had bleeding past, but some have had fall risk, some have had stroke risk, some I've had a patient who works with knives. I've heard all kinds of things. And if I don't think it's a great, reason, a lot of people, or when the FDA released this in 2014, they kind of said, listen, if you have a patient who has a high enough risk of stroke, who has a bleeding issue or a fall issue, or simply doesn't like taking a blood thinner, well, that meets our guidelines. You can put the device in. And to me, that was never good enough, because I really haven't met too many patients who like taking blood thinners. So there are people who sent to me for the Watchman simply because they don't like taking a blood thinner. And for those people, I really try to talk common sense to them. And I say, listen, I think you're better served with being on a blood thinner. And if you ever have an issue, all right, we're here. I have broken that rule a couple of times. There are people who are just so stubborn that they won't take a blood thinner, and those patients, I think, are better served by implantation of the Watchman. But generally speaking, I try to talk someone into taking a blood thinner, even if they perceive that to be problematic. 98% of people who put the Watchman in are off blood thinners at the 45-day mark, and all but one of these patients was off blood thinners for 6 months. So this brings me to another point, which is that this procedure has opened my eyes to doing procedures on patients who are older and sicker. Generally, populations of people who have a lot of concerns about putting under general anesthesia, concerns about doing this procedure in general, but if you think about it, that's who this procedure is really geared towards. And as a team, I think we've really gotten accustomed to working on some of these older, sicker patients because this is really their only alternative. But I will say, on the safety track record, I think is really good, and for that reason, I feel much more confident about doing the procedure, even if someone is older and sicker. But the average age is 78, youngest is 46, oldest is 95. Average CHADS-2 vascular score is 85, so elevated. Yep, so these are pictures of the team. It's probably not terribly, it's not totally inclusive, but I wanted to, so this is us as we've gotten older. This is at 100 and 100 Watchmen. This is at 200 Watchmen. But Dr. Magnus, Dr. Wicks, myself, and the rest of our team, and Dr. Gutierrez, who recently joined the team, have all joined in and doing this procedure. And what I tell patients, I was accused of being a salesman the other day, and I was kind of insulted by that. But actually, the more I thought about it, I'm like, you know what? I'm not trying to sell you on the Watchman, but I'm selling you on the fact that we do this well. We have a really experienced team. We're really enthusiastic, and I think more importantly, you have 3 cardiologists in the room when we're doing this procedure, which I think is unusual this day and age. And Dr. Magnus, who is an interventional cardiologist and very skilled, he has a different skill set than me. He's kind of a plumber, and I'm the electrician, and I think we work very well together. And I think we kind of make it a safer, better procedure because of that. And I think very importantly, Dr. Wicks and Dr. Gutierrez really add an element of the imaging aspect, which is very critical to the success of this procedure. I'll show you why. But it's not just the doctors that make the team. There is a whole host of people that are making this a reality here and not doing the job. So we don't always dress as cowboys, but we did this for Halloween. But we have talented nurses, people who are scheduling the procedures, our nurse practitioners, and Amanda Woods, our arrhythmia coordinator, instrumental to coordinating everything. We have a very good team. And then the lab itself, we have just really dedicated people who really go out of the way to make this experience for everybody a safe experience and work really well as a team. So if anything, I'm the most proud of this. Maybe I'm a salesman. So this is a video of the procedure itself, animation. I don't work for Boston Scientific, and I didn't come to them. But I like this animation because it kind of goes through the procedure nicely. So what we're doing is we're what we call unsheathing the Watchman. We're actually removing it from the plastic tube. It's prepackaged. This happens downstairs in the BP lab. Patients are under anesthesia, and we get femoral venous access to the vein, not the artery. And we thread this plastic tube with the wire and the needle into the heart. This is the left atrial appendage, different shapes, as I mentioned. This is ultimately what it should look like. And I will say this is the first generation of Watchman device. The newer generation, I'll show you this a little bit, is better. So the first thing is we have to do what we call transactional puncture, where we put a hole through the middle of the heart to get into this chamber. This is a routine procedure that we do under ultrasound guidance. Once we get into the left atrium, we then exchange that plastic tube for another tube. It has these markers that you can see here. And we use this little what we call pigtail catheter to place it in the appendage where we shoot IV contrast to look at the shape. Again, I mentioned the broccoli. So it looks like the chicken wing and the windsock. Those are the 3 major shapes. Put this in here. This helps us size it. There are 5 different in contrast so we can get a nice look at the shape, and we'll see an example of that in a second. And then we kind of huddle and we say, what's the right size of device? Then we unsheath the device. So we remove the plastic tube. Hopefully it sits where we want it to sit. And then we do what's called the tug test, where we try to pull it out gently. We have had no devices embolized. We actually shoot more contrast just to make sure that everything is included. And then we release this cable once we're happy. And this is the trick here, is that over 45 days, tissue from within the heart, called endothelialization, goes over the device. A lot of people ask, well, is it a filter? No, it's not a filter, it's more like scaffolding. But what it really does is it blocks that area off from the bloodstream. Over the last 2 years, there's been a really great development, which is the newest Watchman device called the Flex device, and I'll pass this out. Yeah.
What if there are already clots in that area?
That's a really good question. So that's, I kind of mentioned that we brought more people in than we've done the procedure. That's usually the scenario that plays out. So if there is a clot that's already formed in the appendage, we cannot do the procedure, and we won't do the procedure. But what we often do is we have a patient on a blood thinner for a pre-specified period of time, usually 3 months or 6 months, and then we bring them back. And most of the time, we're able to place one of them. That's a very good question. But this new device is called the Watchman Flex. And this is the old Watchman 2.5. And we've been putting this in now, I think, for over a year now, somewhere around there. The Watchman Flex is exciting because it's got this closed back end here. You can see the old Watchman had these kind of sharper tines here. This is completely enclosed. And it has a lot more struts, and it's a lot more flexible. So what that means is it's safer, it's more effective, but very importantly, I can actually now, when we're in here, I can, if I don't like the way it's sitting, I can recapture this, reposition it, and redeploy it. And it was never that easy for the older device. It's made the procedure more effective, safer, and faster. And I know if you guys don't feel all right about touching this, I understand, but I just, it's kind of so this is what it looks like when we're doing the procedure. This is the initial shot under fluoroscopy of us shooting IV contrast in. And this is after we put the device in. You can kind of see the Watchman here, and we shoot the IV contrast, and you can see that it's really well occluded. This is the tug test that I mentioned. This is what it looks like when we're doing it under fluoroscopy. Really, we're trying to pull it out, make sure that if it's going to fall out, it falls out now when we have the cable. This is an example of someone who couldn't get a Watchman. This is the other scenario that can play out, which is that sometimes we look at the size and the shape of the appendage and say, we can't get a Watchman in. And this is one where there's not a lot of depth, and the opening of the appendage or the os is very, very wide. The newer device that's being passed out, the Flex, actually comes with a device that's 2 millimeters bigger than the old Watchman. And so it's actually, it can accommodate anatomies that weren't so accommodated in the past. I was going to say size doesn't matter because a lot of people, you know, a little old lady who weighs 90 pounds can have the largest appendage, and the big guy who weighs 400 pounds can have a tiny little appendage. So you just never know. So I mentioned the ultrasound pictures. There's been a lot of progress with this. One of the technologies is three-dimensional ultrasound imaging. So this is what the Watchman looks like from the inside. Well, that's what it looked like when it was moving, but it's pretty cool. We can really visualize any gaps that we see very, very well. So we have done we've done a few cases that are exceptional, really haven't been done in many places. One of them was recently where there was a gentleman who had a blockage, or he actually wasn't born with full IVC. So the tube that leads from the groin up into the heart was not present. And that obviously presented technical issues because that's how we access it. And this really hadn't been very well described. There were 2 case reports, but we got Dr. Salas, who was the interventional radiologist, to help us. And really what we did is we went to the liver. So he got access into the liver. Dr. Salas was very concerned when the wires were in the heart, and I was like, boy, I'm not worried about that at all. I'm more worried about the liver. But it was a great experience in the sense that we were able to get the Watchman into this patient. This is what the tube looked like coming from the liver, usually down low. And we went right through the liver. We were able to put a Watchman in, and we were able to put the Watchman in a gentleman who normally would not have had that option. So that was great collaboration and innovation. Proud about that. This is a gentleman who we recognize as having very difficult anatomy last year when we put the Watchman in. And so this is after the Watchman was put in, but there was an area down here that was just too large for us to fill. And so what we did was we did a staged procedure on him, as it turned out. And we ended up having to occlude this area only 6 months later with something called an Amplatzer device. It kind of looks like the device I showed earlier, but on a smaller scale. And we were able to occlude that area with this device sitting next to the Watchman. Again, this is collaboration. This is what it looked like before we released it. You can see that that area that was kind of that had open appendage is now closed. This is what it looks like with ultrasound. You can see this is down here is what it looked like with the closure device, and the 3-dimensional pictures really show that the whole area is closed off. This is a gentleman who had a brain bleed, who also had a regular embolic stroke. He really needed something because being on a blood thinner was not a good alternative for him, and being off a blood thinner wasn't. So we were really happy and thrilled to get him off blood thinners, and he's been doing really well since. So in conclusion, left atrial appendage occlusion is a proven, safe, and effective alternative to anticoagulation. Again, Concord Hospital offers a collaborative, team-oriented, innovative approach to these procedures. Really proud about that. And in the future, I think there are newer technologies. I think we will possibly be able to do these at the same time as we do ablations, which are procedures that we do in an effort to keep people out of atrial fibrillation. So with that, I thank you. And if you've got questions, rebuttals, anything. Yeah.
During the procedure, you mentioned a 3D ultrasound. Is that really all you need to see what you're doing, or is there also live radiography?
So the images that I showed you all radiography, so it's both. So you actually look. So this is fluoro or X-ray, and this is an ultrasound. So all these patients have both. So we have multiple ways of looking at the same thing. And for the record, the 3D is adjunct. It kind of helps us. It's really 2D that we rely most heavily on. But we rely very heavily on the skills of Dr. Gutierrez and Dr. Wicks. It really makes or breaks the procedure. That's a good question.
What's the longevity for this implant?
Well, that's a good question. And, we honestly, one of the, so I've seen very young patients who, for whatever reason, want the Watchman. And one of the things I tell them is that with any newer technology, we really don't have the longitudinal data to really know the answer to that. But the meta-analysis that was 5 years old, and they included patients who actually had the device probably now upwards of 10 years, they've been doing well. The device lasts as long as you do. Really, again, it's scaffolding. All you're doing is having tissue grow over it. There have been case reports of the device eroding, more so with the Amplatzer device, but that has been reported. I haven't seen that, but nobody knows what this means in 20 years, which is why my bias is to place them in patients who are a little bit older unless you really have to put it in somebody younger. But it's a valid question.
Any perforations of the atrium putting it in? Reported case of the atrium being perforated.
Oh, yeah, oh, of course, yeah. That's the most common complication. Actually, as it turned out, when the Protect trial, the Prevail trial, excuse me, was released, the original trial that said that, well, it looks like it's the same type of procedure, it actually had about a 4.6% rate of complications, mostly made up of perforation. So perforation is the doctor way of saying that you put a hole in the atrium. And that was not acceptable to the FDA. So what they did is they came up with another trial called the Protect trial, and it wasn't powered to really look at outcomes other than complications from the procedure. And what they did is they ensured that patients were getting the procedure from doctors who were very comfortable doing a transactional puncture, because there was a bit of a territorial issue with interventionalists and electrophysiologists. Interventionalists really weren't comfortable doing the transactional puncture. Electrophysiologists routinely did. A lot of the perforations were a result of that. So they only included doctors who were experienced doing that, and the complication rate dropped to 1. For the Flex device, there's a newer trial called the Pinnacle trial, and actually it showed that there's a 0.5% risk of perforation. My experience, we've had a couple of perforations. Both of them recovered well from drainage, and these were actually a long time ago. They haven't occurred with the newer device.
So it's basically a pericardial drainage. You didn't have to open it up.
We did not, but thank you for asking that.
Yeah.
You know, we're conservative. We want to do the right thing. We do this with the surgeon and the surgeon's team available, and we don't cut corners when it comes to that, because if you create a hole in that appendage it's so thin, it can be devastating very quickly. But those patients did fine with surgery. That's a great question.
So the ideal candidate for a Watchman is somebody in chronic atrial fib who doesn't want to be on anticoagulation.
Can I stop you?
Okay. I was just going to say, when you do a successful ablation, somebody's no longer in atrial fib, but might you still place a Watchman?
Those are some great questions. I don't know how much time y'all have, but I wanted to stop you because the term chronic atrial fibrillation is no longer accepted. That is not a viable term anymore. Chronic atrial fibrillation implies that a patient is stuck in AFib. So for us, the categories are permanent atrial fibrillation is a patient who we are giving up on trying to get into a normal rhythm. A patient who's been in persistent atrial fibrillation, that can be long-term or short-term, basically a year or greater in AFib, or paroxysmal atrial fibrillation, in and out of atrial fibrillation. As it turns out, there's no difference as far as stroke risk. If you're in permanent atrial fibrillation or you have paroxysmal atrial fibrillation, you have risk of stroke. All right, so it's kind of counterintuitive, but there's actually some data that I've read that suggests that paroxysmal patients have higher risk of stroke than persistent patients. The other question you ask is a great question, and so patients are often sent to me for ablation, and sometimes they say the only reason I want the ablation is because I want to come off blood. And I look them in the eye and I say, this is not the right procedure for you. I will never ever do this procedure for someone whose sole intent is to come off blood. And the reason is we have no evidence, zero, that we have mitigated anybody's risk of stroke by virtue of me doing a great job on an ablation. Believe it or not, if I do an ablation and I prove that you haven't had AFib over a year or two, there's no evidence that I've mitigated your risk of stroke. So, and this doesn't make a lot of sense, and I kind of get the sense that this will change with more longitudinal data as ablations are more prevalent. But the guidelines are very clear. If you have a patient who is on a blood thinner before the ablation, even if you do a good job, you should keep them on a blood thinner. And again, we don't exactly understand why that is, but doctors now think of it as a marker. We kind of conceptualize AFib as a marker of stroke risk. And more importantly, after I do an ablation, I can take somebody who's formerly very symptomatic and turn them into an asymptomatic person with AFib. Again, we're not clear why it happens. It happens all the time. I see it. and that's great. I'm trying to improve upon your quality of life, but it does nothing to improve your risk of stroke going forward. And so I always get concerned about that. Did I answer your question? You don't like the answer, but.
Does the Watchman have a role to play in somebody who
Yeah.
no longer goes to the
Yes. This is the other thing that happens, which is that we we follow about 2,000 patients with pacemakers and defibrillators. Great. Well, it's changed our practice because all these pacemakers and defibrillators have the capability of sending what we call remote transmissions, lots of data to us. And what we do with that data is like, oh boy, so if somebody has 2 minutes of atrial fibrillation, is that enough to warrant anticoagulation? Well, historically, doctors have always thought that you needed to be in atrial fibrillation for 48 hours in order for a clot to form. Well, that's actively being debunked. We think it's much less than that. But how much less? Nobody really knows. So, so yes, there actually, if you have 1 minute of atrial fibrillation before an ablation, well, we know that it progresses, you're going to have more AFib going forward. So the thought is, boy, that 1 minute will be 1 hour, it will turn to 10 hours, it will turn into a week at some point in time. So yes, you are still a candidate for the Watchman, even if one has done a great job. And in fact, last Friday, I did one on a patient who I did an ablation on 2 years before, hasn't had a lift of AFib, but she wanted to come off the blood thinner for a variety of reasons, so I did it for her. Is that right?
Yeah.
I have a kind of a two-part ablation, even though that wasn't the topic.
Yeah, that's right.
Sorry about that.
Nope.
Just out of the 200 plus patients that you've done, how many have had ablation successful or unsuccessful prior to Watchman?
I would guess it'd probably be 50 to 75, 50 somewhere around there, I guess.
And then there was a really interesting couple articles in the New England Journal about 6 months ago about way of doing ablation. Is that how we're doing it here? Kind of going through the septum and dealing with the pulmonary veins back to the pulmonary veins. Is that the way it's being done here?
Oh yeah. We're very modern. We have all kinds of modern equipment, but we
How
do.
long have we been doing it that way?
So we have two forms of energy: radio frequency, which is burning, and freezing. And I was the first and only doctor in the state for a number of years since 2014 doing the cryo, which is really they're equivalent in our literature, but anecdotally, I find that the cryoballoon works better and is tolerated better. And I think there'll be data that probably supports that going forward.
The data was pretty impressive.
Well, it's I tell patients it's not perfect, and outcomes in my world are fraught. So if I take a patient who's been in AFib for 2 years, let's say, and they literally have 1 minute of AFib over the next year after a new ablation, that's actually technically a failure. But that's not real world experience. So if you actually look at the data, and you know the earlier you get to someone, the better the procedure works. But you would actually make remarkable improvements in quality of life. Because if you're taking somebody who's symptomatic, having a lot of AFib, and now not having as much, they're fine. I will tell you, this is a really exciting area because there's a new form of energy called electroporation. I won't go into it. Will make the procedure, I think, faster, safer, more effective, hopefully the next couple of years. But I argue that the procedure itself has really come a long way. The guidelines are really telling us to get to people earlier, and that you can skip medications where formerly you used to have to at least consider them. So it's beyond the scope of this discussion, unfortunately, but a very good question.
I just wanted to mention the comment that was one of our Facebook viewers from Arthur Russell. One of the best doctors I know, saved me more than once. Thank you, sir, many times over.
You make me blush. He's a good guy. But well, thank you very much. I
Any other
appreciate it.
questions? Yeah, I think we have another-
Sorry.
No, it's all right.
So has the device ever been rejected once you replaced it?
That's a really good question. Never. Not for me, and it would be reportable. But we have had, so it's an alloy, nitinol, but it has nickel in it. Very small amount. We did have one patient who had a severe allergy to the nickel. So what we did is we sent her home with the device taped onto her forearm to make sure it was all right. And she did fine. But no, it hasn't. And that would be reportable. And remember, it's not in the bloodstream after a period of time. That would be a major concern we have with that. But the alloy and the materials have been very well studied and used for other devices. thank you so much.
Thank
Thank you
you.
so much for the great presentation. Thank you, everyone here, joining us for What's Up Doc, as well as our virtual audience. We hope you'll be with us next month on Friday, December 10th. Dr. Michael Ferguson, also from the Cardiovascular Institute, will be our guest speaker. He will be talking about minimally invasive heart pumps to support critically ill cardiac patients. On behalf of the entire Concord Hospital Trust staff, we wish you a very happy, joy-filled Thanksgiving. Stay safe, stay healthy.